Hello, everyone. Thank you for joining us again for this Fireside Chat number 2. I'm Roxanne Thompson. I'm a clinical director at the Institute for Attachment and Child Development, and Beverly White is our lead senior therapist. And we're going to discuss today some things that are probably on everybody's mind that have adopted children. And we've been asking parents to send in questions, and as we receive those, we kind of put them into a bit of a running format so that we can kind of keep things kind of together, because there's all kinds of different questions coming in. And so we're going to answer the ones tonight that we are discussing that kind of fit together. So keep sending in your questions, because the more questions we get, the more fireside chats we will have. And I will let Beverly tell you what the next one is going to be. It's going to be very special.
The next fireside chat will be with Sarah Bennett, who's our, I don't know exactly what her title is. Roxanne, what is Sarah's title? She's a therapist, and she works with
offense-specific.
Sexual offense-specific cases.
Yes, with
and I will
sexual
have
dysfunction,
the next.
sexual behavior, yes.
Mm-hmm. So she and I will have the next fireside chat, and we will talk about offense-specific treatment and reactive attachment disorder and trauma, and how if you have reactive attachment disorder, you are not typically or necessarily in the offense-specific recovery, and if you're in offense-specific, you are not always in reactive attachment disorder. So they are not always, as we say, co-morbid. They don't always go together. So that will be the next one. So send in your questions. Sarah is very knowledgeable and very articulate, and it will be a good fireside chat. But today we're going to speak more about adult reactive attachment disorder and also child family therapy for attachment disorder and trauma. So that's our start off for today. Following up with some leftover questions from the last time. And question number 1 says, just saw your fireside chat and found it to be very helpful. You mentioned attachment issues can exist on a continuum. How can we interject resolving attachment issues with our 16-year-old this late in the game? So I think I'll start off answering, and then Roxanne will jump in, and we'll just chat back and forth as we typically do. So number 1, the rest of that question says, this person has 2 adopted sons from Russia, ages 14 and 16. It's been true for our family that each of them went through attachment issues very differently. Our youngest was diagnosed with autism and had very clear attachment issues early on, so we did attachment therapy early on. Our older son is gifted and very able to negotiate the academic world, as well as being great at adulting. He was diagnosed 2 years ago with bipolar and has since been medicated, lost motivation, including academics, sports, anything competitive. It's as if he lost his impetus for anything. I've thought many times since his diagnosis that he's now dealing with attachment issues like never before. Now he's become a daredevil and a risk taker. So number 1 on this one, please go back to the psychiatrist and talk to the medication for medication management. That's critical. The psychiatrist needs to hear that the motivation is gone, and it looks like most areas of your son's life. So the psychiatrist, first of all, needs to be addressed to talk about what medication results there are, and if there's a favorable response or an unfavorable response. Having said that, daredevil and risk-taking behavior are not uncommon for a bipolar diagnosis. You know, we see that often. It's not always there, but it's not uncommon. So go back to the psychiatrist. The other piece I wanted to talk about is the emotional age versus chronological age. So you're talking about looks like a 16-year-old But emotionally, with reactive attachment disorder, he could be 4 or 5. How old, let's see, was he when you, doesn't really say how old he was when you adopted him, but I'll let Roxanne talk about a little bit more about how the reactive attachment disorder causes what we call arrested stage of development because of how it affects the brain. So Roxanne, can you talk a little bit about how the brain's affected from the trauma?
Yes. You know, when there is a disruption in the attachment, if there has been trauma of any sort, sometimes it's frequent and very intense trauma. Sometimes it's one huge event. We can never distinguish in some kids which it is, but this developmental trauma actually is very important to know where the child had their most of their trauma. Because at that point, you may have even a 35-year-old who will regress in some ways under stress. And so the brain kind of collects all that information and just kind of in the limbic system where it doesn't know time. And when anything in your environment triggers that, a person is going to react to their environment. So if you've got a 14 or 16-year-old who was adopted from Russia, my guess is they may have been in an orphanage, and that in itself creates a lot of developmental trauma because of the lack of care and nurturing and possibly nutrition. Depends on the orphanage. Some are actually better than others. So you also don't know with a child from another country, especially where you can't get records, what is the medical and psychological history of the parents. So you really have with children that this parent is talking about, you have a lot of places where you have to take in consideration, because that little brain has trauma and it holds that trauma. And no matter what's happening in that child's world, they're going to revert back into some of that behavior, or at least the fear or a trauma reaction. And you will, and you know, they can be very sophisticated in how they do that, even though it happened at 4 or at 2 or 6 months. As we grow older, we get more sophisticated in how we do things.
But the brain still stores the trauma. And as it stores the trauma, it also stores the adrenaline that goes with the trauma.
True.
So the adrenaline can be triggered if the individual perceives a threat to the individual's survival. And then that will release the adrenaline, and you will see the maladaptive behaviors or the historical survival patterns surface, which will look to us often like maladaptive behaviors, but it's the individual doesn't clearly always know where those triggers are coming from or why they're having the reaction, but it clearly is a gray matter of the brain issue.
And so imagine that you're a teenager and you have all of this trauma in your background. You also come from a different culture. I don't know how old these children were when they were adopted, but if they already had language, they also have language barriers possibly. And you have also just a typical developmental place where teenagers are. They can be daredevils. They can have risky behaviors, just typical teenagers. So you have to be able to distinguish what's trauma-based and what's just normal. Okay, I always say that kids with trauma, kids in the foster care system, kids have been adopted, do everything that every typical child does, but they do it up here.
Right.
It's exaggerated. Okay.
Yes.
So that may be what this parent is seeing. You've got the bipolar disorder. as well that has to be treated medically. You will not be able to wish it away or exercise it away or do anything. That is a chemical imbalance in the brain, and it
Right,
is biological, and it has to be treated with medication.
right, right. So I think we very well covered that. Roxanne, do you want to address the second
Sure.
one?
Yeah. The next one is, my 24-year-old daughter and I are not interacting well. Graduating college, starting work in a town with no friends has triggered her anxiety, and she lashes out at me. I'm think I have PTSD. We both need help, but for now, how do I move forward? Well, it's really tough when you have an adult child, because they also have to be willing to get help if they need help. That's always an issue for a lot of adoptive parents who have adult children. Um, so she kind of set herself up by moving to a town with no friends. And if she's had anxiety and depression in the past, that's just going to exacerbate that. So I think that one thing that you might be able to do as a parent of an adult child who has put herself in a situation that might be anxiety producing is that you make some visits, you do some things to support, even though those visits might not go well. The message is, I'm still here. Just because you're an adult doesn't mean that I've left you. And I know that you really don't have too many people around you. So, what can I do to help? Ask what that person needs. That's another tip. We do that with little kids. What do you need? Because sometimes people know, sometimes they don't. Um, and the anxiety piece, if she's not doing something about her own anxiety and taking responsibility for that, she might be able to go and have somebody take a look at how they can treat that for her so she feels better, at least for a little while, till she settles in better. And remember, moms out there, you are the ones who catch it the most, because it goes all the way back to the birth mom and the separation from the birth mom, and that disappointment and anger and rage and confusion, and the moms always catch it. So it's no doubt that you're not interacting well at this point, because she's being triggered with her anxiety, being alone, not having anybody around. So you are the one who is going to kind of catch that.
And
The
she
only
may
thing
be
I
in
can say
denial.
is, the only thing I can say is, don't take it personally.
Yeah, yeah. One tip I would support for consideration is to first seek help for your own post-traumatic stress disorder, to separate out your anxiety from her, so that you're not then projecting your anxiety onto her. She may have a lot of anxiety, which she likely does, but she may be in denial about it. As we say, denial is a very deep river, and she might want to keep floating on that river for a while. So take good care of yourself, number one. Get a treatment for your own post-traumatic stress disorder. There are various forms of treatment. There's EMDR, which is eye movement desensitization and reprocessing. There's something called brain spotting. There's also called thought field therapy, which they call tapping therapy, right, by Roger Callahan. And that can help you with your own PTSD. It can give you strategies to take care of it on your own. So I would say, first of all, recognize, she has set herself up there, going away from her secure base, her security. But also, please take care of yourself first, so you can separate out your own post-traumatic stress disorder from what her anxieties are. I don't have anything else to say on that one. Roxanne, do you?
No, I think it's a matter of kind of tiptoeing through that, being as supportive as possible to your daughter, and also taking care of yourself. Um, If she is not ready to make some moves in that direction, there's really nothing that you can do with her except
Yes.
just support her
Be
and give
there.
her those messages that you're there.
You're there.
Yeah, yeah.
That kind of rolls into our next one. It says, what are viable treatment options for an adult with RAD issues? We have a 25-year-old adopted son that did not get the diagnosis until he was 15. We adopted him at 7, and he was with our family since the age of 3. He has not been treated for RAD as there were no options at the time of the diagnosis. He has very detached and dysfunctional relationships, and he still has classic textbook symptoms. So first of all, we have to say he's an adult. He can choose whether he wants to recognize he has issues or not recognize he has issues. You can't force it. And then if he recognizes, he has to choose whether he wants to have treatment and get some help or not. He may say, no, it's not that bad, or maybe have a lot of defense mechanisms around that so that you can't force treatment. He has to be the one to choose. If he chooses, then it would be wise to find a reactive attachment therapist / trauma therapist who works with adults. And that would be the best avenue for him to seek. But again, you can't, if he's an adult, it's his choice.
And that's true. And through the years, I've seen a lot of adults that have attachment issues into their adult years. And it's very evident when you see them having, really poor relationships. They're in and out of relationships. They don't understand why they don't work. And so that would be the focus of the therapy for someone who is an adult, to explore their intimacy issues, their attachment issues, and see, what somebody in the therapeutic environment can help them to start having some awareness of what their part in that is, and maybe make some changes.
Right. It's not their fault. It happened.
Right.
And it's not working well in their adult life. They have the intimacy issues, they have trust issues, and they just need some help with that to recognize, as Roxanne said, what their part is, so they can address that themselves. So Roxanne, you start with the next one?
Yes. What are some suggestions to assist someone who was adopted at an early age with current attachment issues as an adult? I guess I'm with this, didn't give us a whole lot of information whether that the adoption issues were evident as a child. So we don't know that, but it would be rare that somebody would go through their childhood, especially if they were adopted at an early age, and they have attachment issues as an adult, that you wouldn't know that. So again, assisting someone who was adopted at an early age, it doesn't really matter when they were adopted. The issue is, where was the trauma that created the inability to attach and to bond with others and have reciprocal relationships.
And closeness, yeah, that closeness,
Yes.
the fear
Yes.
of closeness, because sometimes we see attachment disorder looking like extreme codependency. Sometimes we see it looking like anti-dependency. So you can look anywhere on the spectrum. There are some books that I could recommend that might be helpful. One is called I Hate You, Don't Leave Me. And although that's written for a different population, it is relevant to the RAD population as well. The other is The Face in the Mirror.
Yes.
And then John Bowlby wrote a book called A Secure Base. That's just the foundation. Relationships. And then Bessel van der Kolk has written so much, but the book that I would recommend is The Body Keeps the Score. So how the body stores the memory of the trauma, and then what to do about that. So those might be some starting points for reading. I think some suggestions also would be role model healthy boundaries for someone who has attachment issues as an adult. They don't always know where they stop and someone else starts, where they end and where someone else begins, because they haven't learned that. Actually, it's not innate to them. It wasn't given to them, so they did not develop a neural pathway for it. So role modeling good boundaries is a start as well. And then, you know, getting the diagnosis and an appropriate trauma therapist would be wonderful. But in the meantime, they can do some reading, or you can do some reading, whoever submitted this, and see if that would be helpful.
Yes, and I think one thing that you just said is to find a good trauma therapist. Your, you know, everyday therapist does not necessarily understand trauma the way somebody who's trauma informed does.
Right.
And so they would not be as helpful to someone who's struggling with those issues. So make sure that they have a pretty good background in trauma and understand that early childhood trauma.
Trauma and arrested stages of development, right?
Mm-hmm.
So
Yes.
how do I explain that I'm not a child abuser or neglectful to the courts and others? I've been raising 3 reactive attachment disorder grandchildren for 11 years. Counseling was not helpful, and when I don't do as my children wish, they act out very badly. I waffle between trying to help my kids and protect myself. My heart is broken. Well, our hearts go out to you because your heart is broken, and it's continuing to be broken by the disorder that the children carry with them. So you would need a good, again, reactive attachment / trauma therapist who's trained in sibling trauma bonds. Because what we see happen historically is that children adopted together, siblings, have a bond, a trauma bond, because they've been through the trauma together. They've been through traumas together, so they rely on each other for their survival. So they don't develop a sense of, gosh, I need parents to help me survive, because in attachment disorder, that's not a known concept. So the children, though, siblings will bond to each other and then resist bonding to the attachment figure, to the parent. And more often than not, the parent can't see this. But if you think about it, you probably will recognize it, how the kids are relying on each other and saying, well, I don't need you to be my parent because I've got Sally, Susie, Johnny, whoever. So that is a big piece to recognize, and to find a therapist who is skilled in working with sibling trauma bonds, you know. So that's a more specific area, I would say. In the meantime, in order, if you're dealing with the courts, documentation and a paper trail is needed. So I would support consideration of keeping a paper trail of the child's behaviors. A few other things, again, setting your boundaries, role modeling good boundaries, and you're going to need breaks. You're going to need either summer camps, or consider joining a parent reactive attachment support group. I would say mentor programs, as long as you had a mentor for each child, separate mentor, but the mentors would have to understand trauma and reactive attachment disorder. So it gets tricky in there, but you're going to need some relief because you have 3 and you've been parenting them for 11 years. And my guess is you have some of your own post-traumatic stress disorder by this time and need to find to take really good care of yourself. But documentation and keeping a paper trail is also good taking care of yourself. So I've probably talked more than I wanted to about that for Roxanne to jump in. So Roxanne, I'll be quiet while you jump in there.
Well, I also am concerned that you have 3 rad children in your home. 1 is difficult, 3 is impossible. And so I repeat what Bev said about our heart is broken for you, because it is a tough situation. And that trauma bond is huge and it's real. So I also have a suggestion that they see different therapists, because that will separate them out and it gives them the space to work on their own issues separately, and then being able to come back to the family. If it is impossible with all three, it will change the dynamics in the home for one child to have a brief stay in a residential or some type of program like ours, or you know, somewhere, so that that child is out of the home and there's only two for you to deal with, and there's only one for the other to deal with, instead of two other kids for them to deal with each other. It lowers the intensity in the home.
Stress.
So that's just another suggestion for that. It's a tough situation. Yeah, you might want to reach out to us a little further on that one, whoever wrote this.
It's so tough. That is so tough. It's incredibly tough when you have two that are trauma bonded, but three, it's just, it's really hard.
Yes. Okay, so the next one is, what specific training should parents look for when identifying a potential RAD therapist for our families? Okay. There's no specific training for RAD kids to work with RAD kids. However, it is, oh, there's more light on the subject. Thanks, Bev.
Yeah.
Oh, we can see you better.
It got dark outside, so sorry, everybody.
Well, I've got a thunderstorm going on behind me, so I don't know if you can hear it or not.
A cloud came over.
It's just normal, you know, fireside chat.
Yeah.
So, you know, a therapist who is trauma informed and may have taken courses in trauma, who has experience working with children who are difficult and have many challenges in relationships. When you interview a therapist, you really have to talk to them about what do you understand about reactive attachment? What do you really understand about developmental trauma? What do you really understand about, you know, how the loss of the birth mom, the birth family, do you understand how that impacts a child for life? There are many questions that you could ask in interviewing that person, but you have to, number one, they have to really have some training in developmental trauma.
And have practiced in the trenches. Roxanne and I talked about this before. You can learn about it in books, but until you have been in practice in the trenches with these kids, with the trauma, it is a completely different world. Reading about it and saying I've studied it and I've got a certificate in it, or I've got this, until you have actually been with them and in the realm of their chaos and their trauma, you know, you don't grasp it yet. You really, so find someone who has been, as we say, in the trenches, and in the trenches for a while, because Roxanne and I could write our own encyclopedias of experiences. And you want somebody who has experience. So you also want a therapist who has other colleagues, you know, to consult with. Like, we bounce ideas off of each other all the time. It's like, okay, what about this? And we've both been in practice forever. I don't even want to say how many years between the two of us, but we still need to bounce ideas off of each other, and also a psychiatrist. So you want a therapist who has backup with colleagues and who has backup with a psychiatrist as a go-to. That's really, really important. A highly informed trauma reactive attachment therapist will not try to make friends with your child. They will make sure they are leading the session, and they will not try to cozy up when the child tries to be superficially charming or try to take lead in the session. They won't go there. The therapist will say, oh, thank you for that thought. Let's move on to this. You know, they will continually take the lead. So, and a healthy attachment therapist knows that attachment is a two-way street. So you need the parents in there because the parents are the attachment figure. So you're going to have an attachment figure to attach the child to. So if you're with a therapist who says, no, you can't come in, that's a red flag. So be careful with those kinds of things. Roxanne, did you have another thought about that?
No, I think you pretty much have covered that, you know, it's finding your team. You got to find your team that's going to work well together.
Yes. And it's a team. It's a team effort. It is a team effort. Yes. We're very fortunate that we have each other and we have the Institute because of our milieu, of our family model, of our psychiatrists. We all have access to each other 24/7. And that's unusual and it's wonderful. So but it is the team approach.
Yeah, and it also keeps people from being burned out.
Or splitting, or being split, because, you know, kids are not necessarily accurate historians. So,
right.
The team approach we have keeps the level of splitting or triangulation down to a minimum.
Exactly.
Yeah.
Here's our next question. I'm worried that sending my 11-year-old internationally adopted child to an RTC or to a program like yours would make her feel like we have given up and that we are giving her away. Isn't leaving the family just another traumatic experience? She often says that we wish we would have never adopted her, that we don't love her, and we wish she would leave or die. It is heartbreaking. The more she pushes, acts out, and says things, the more truth there is in her statements, which makes me feel that much worse. Can understand that for sure.
Yes.
We don't know what to do anymore. She is charming to her therapist and knows how to say all the right things, but will be back screaming at me as soon as we are in the car. Something has to change, but I don't want to make it worse by sending her away to treatment. Does that make any sense? I really feel like I live in an opposite world. It makes a lot of sense, but I can tell you, treating children with reactive attachment or attachment issues or trauma is counterintuitive. So in our I can only speak for our program, but in our program, the parents are absolutely 100% involved in the treatment. You don't send your child away and you don't see them again for 6 months. You talk to them every week. You are in therapy with them every week. You have a phone call every week with them on the weekends. You write letters. They can write to you. There is a lot of contact. So we don't ever think that we should just abandon a child in a program. So when you have a child leave your home and they're in a program like ours, it's giving everyone a break, because the more the child stays there and the more incidents happen and the more awful things that people say to each other and the more hurt there is and the more fear that is built up on both sides, it never gets healed. With the child leaving and giving some space between the parent and the child is really healthy. And we work really hard to make that connection even better, and maybe better than it ever has been. Bev, you want to interject there?
I have quite a bit to say on this. You feel like you're living in an opposite world because you are living in an opposite world. You're having the expectation that your child has joined your family. your child mentally has not decided yet to join your family, because it sounds like your child is still doing what we call the attachment dance, which is the come here, go away, come here, go away, come here, go away. That's the attachment dance, and that's what you're describing here. So she wants the love, but she's not letting the love in. The trauma creates the anxiety that says it's not safe to get close, although the child really wants to get close, but then they're going to push away no matter what. So it is an opposite world. They think they're in charge of themselves and their lives, and you think you're in charge because you're the parent, because you are in charge. It clearly, and it is, I call kind of crazy making, because sometimes they act like they want your love and they're all on board, and then they're not. So they're in their survival mode from the trauma, which is a neural pathway for survival. That is ingrained neurologically in their brain to survive. And then these are the behaviors that you're seeing as an outcome of that need to survive. So once they decide to join the family, which we hope that they will once they come to the Institute for Attachment Child Development, with the therapeutic treatment families, they practice how to be family kids, okay? So then they can make the conscious choice. In therapy, we help reduce the stress and the anxiety so the child can decide, make a conscious choice, do I want to be a family member? And more often than not, once that stress is decreased and they can make the choice, they will make the choice. But it's a rocky road getting to that point. They do need the practice family at the Institute. And while we're helping the children decrease their stress and deal with their grief and loss and the trauma associated with that, we're also teaching the adoptive parents new parenting strategies for parenting kids with trauma, okay? Because like Roxanne says, it's counterintuitive. It just is not what you would naturally think. So to parent a child with trauma, you need new parenting strategies. So we're doing that simultaneously while we're working with your child. And you will see that happening in therapy itself. The phone calls are not therapy phone calls. The phone calls for you with your children are to say, I love you, how are you doing? Have a little catch up. But the therapy is where we address the grief and the loss and the trauma, and also teach you the new parenting strategies. So let's see if I had anything else. I just wanted to validate that you are living in an opposite world, and that it's crazy. The attachment dance itself is crazy making. That come here, I want to be close, no, go away, I don't. I mean, that is just a crazy making thought and feeling. I want to be close, no, I don't. So it's the push-pull. And it's difficult, it's wearing, it can be quite exhausting to live in that. So once they decide to join the family, then you won't feel like you're in an opposite world. Then you'll be in the same world.
I want to address also, Bev, where she's charming to the therapist and then knows all the right things to say.
Yes.
That's a perfect example of survival, number one, because nobody really wants to take a look at the hard stuff in their lives.
And it's hard.
Especially kids. And also, therapists may not be skilled enough to work with a child that's that manipulative.
Yes, 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 yes. It's the child who gives you the maladaptive behaviors at home, but goes to the neighbor, goes to therapy, or goes to church or wherever, and looks charming and delightful. You know, it's more the crazy making part. But yeah, so the therapist has to be skilled to recognize that as one of the survival behaviors. Mm-hmm. Yeah.
Exactly.
Yeah.
Okay. I think we can move on to the next one, Bev.
I think so. I'm just checking here to see if I wanted to add anything else to that, because those parents need that validation, because they're just not being trusted yet. You know, the kids aren't trusting them to do the parent job because the kids still want to be their own parent.
Right.
Here's the thing. The trauma and the attachment disorder creates rejection sensitivity, okay? So the child is sensitive to rejection, but on the other hand, the child sets up the rejection. So they're sensitive on one hand, like don't reject me, don't abandon me. And on the other hand, they're pushing you away and saying, you don't want me. So it's really dilemma, but if you can recognize it, then you can work with it. But it's called rejection sensitivity is what it's called. And whether it can be perceived, it can have nothing to do with the reality. Oftentimes their reality is quite distorted. They're not quite in the same reality we are because of the trauma and the survival mode they're on. So just be aware that it's rejection sensitivity and it's chaos in their brain, and they're not aware of what they're doing all the time. Rarely are they aware, except when they're manipulating. They're aware they're manipulating. Okay.
Exactly.
All righty. Let's see, Roxanne, what is the next one? Do residential treatment centers actually help kids effectively learn coping skills, how to respect boundaries, or to acknowledge their emotions? You know, this is what I would call a loaded question, because all residential treatment centers are not the same. And I can't speak to any of them actually, because I don't know the protocol or the programs in each and every residential treatment facility. Some teach coping skills, some teach boundaries, some work on emotions. I think the main difference is that the Institute's model is a family model. And it's a comprehensive family milieu with the psychiatrist, with the treatment families, with the therapist, with the relief providers. You know, we just cover all the bases to replicate a family setting as much as possible so the child can practice healthy family behaviors. And I don't know that residential treatment centers do that. I don't know that they don't do that. I just don't have enough knowledge about RTCs to answer that intelligently.
I do get, when we have inquiries about our program, I do talk to parents where the children have been in one RTC after another, and it hasn't helped them. So I don't know if it's just the child won't work with the people that are there. I don't know if it's the program that they have. I don't know. But when a child is needing to heal, their ability to relate to people, to have reciprocal relationships, to bond, to attach, to heal their trauma, all of that, they really do have to have some boundaries. They really have to be in that emotional box. They have to know what to expect. They have to be able to talk about the feelings that they have and have the language to do it. They might be 16, 17 years old, but if they really don't know feeling words, they're going to be very frustrated to not be able to tell you how they feel, put a word to feelings. And so the only way they have to tell you that is to act it out. So if those things are not being taught, and also how to cope with different situations, if they are not being taught in any program, it doesn't matter if it's an RTC or it doesn't matter. If those things are not being taught, they are not going to be able to live in a family in a peaceful and respectful manner. They're not going to have positive and healthy relationships.
And I don't think they know what boundaries are. I really don't think, you know, the children with the trauma recognize, again, where they stop and someone else begins. I think that the word boundaries might be a foreign concept to them. So they're going to have to be taught effective boundaries, you know, what their identity is, where they stop and start. And like you said, most often they don't have language for feelings or emotions, and we really have to teach them what feeling goes with what word, what that emotion is, so that they can learn to verbalize, because the kids we have that come to us have no clue what that feeling is other than mad. They have everything is mad, everything is mad. One little girl, everything is sad, you know, but they don't have a vocabulary for what they're feeling, and they need to be taught that whatever environment they're in.
That's right.
That.
That is true. Okay.
So it says, what are some ways to maintain progress once your child has been discharged from an RTC? Well, again, not an RTC person here, but I would support consideration initially of maintaining medication management with whatever psychiatrist that you have on board and that you trust to continue at least mental health stability, mood stability, whatever needs to be addressed, whether it's ADHD, whatever it is, to maintain the contact with the psychiatrist for proper medication management. That would be the first thing I would suggest. What about, Roxanne, what would you think?
Well, and also maintain the language and the strategies that maybe the therapist has been using if it's been successful in the RTC. So if the child's been making progress, you would want to continue that at home. Like when our children are discharged from our program, we work with the parents long enough to say, this is how you need to continue. And sometimes we do a little tune-up once in a while afterwards. And, you know, always having somebody that is trained after the RTC experience in what they are doing in the RTC. So you're going to want your hometown therapist or your therapist to talk to the therapist at the RTC and see what they've been doing. How have they been addressing things? I think just that continuity of care is very, very important.
Right, right. Absolutely. Continuity of care, continuity of language, strategies, all of that continuity, and consistency. Consistency is key. Consistency.
Yeah, I agree.
RTC versus the Institute for Attachment and Child Development, what's the difference? Well, IACD, as we call it, also has a neurofeedback component. I don't know that RTCs have that. We're about relationships, family relationships. So it's a practice family model is what the Institute is. It's a minimum of a psychiatrist, the therapist, the therapeutic treatment family, the respite providers, the neurofeedback, the clinical director, executive director, hometown therapist has to be in there, and whatever representatives from the child's family are. So it's a huge milieu treatment model, but it's about family relationships. So that's, again, why we're teaching the parents parenting skills to support their child's resolution of their grief and loss and trauma. So to build trust, you know, the kids come on their own survival mode, so they're not trusting us, they're not trusting their parents. So we teach that. And it begins, our program begins with a psychiatric evaluation. So before a therapist even gets to work with a child, our children have had psychiatric evaluation, which means diagnosis. And if there's any prescription for medication management, that is given during the psychiatric evaluation. Because when a child comes, if their brain is highly dysregulated and chaotic, the therapist really doesn't have a child to work psychologically with, because their brain's dysregulated, and they need to be able to calm and stabilize for the therapist to be able to have that conversation with them to talk about things. So that's the first part, the psychiatric evaluation. And then sometimes there's no medication involved, other times there is. So that's critical to have that first. So we try to replicate a family where, you know, the kids learn to trust the parents as leaders. And learning how to interact with siblings, we have the kids practice that, and how for them to practice having fun in a joyful way that's appropriate, not at anyone else's expense, and not being in control of all the games, or, you know, how to share turns. So it really is more of a family model. And as we say, we're always the beginning. We're not the end, we're the beginning. But once our children are able to relax the dysregulated brain, to calm, then they make the choices to decide to learn how to be the family kid, the family child.
You know, and also our milieu is very different. In an RTC, you have pretty much a locked hall, residential hall, or cottage, where there are many children and staff going in and out, you know, and that's not the best consistency for a child who's actually learning to trust. So in what we have are treatment homes, therapeutic treatment homes, with a maximum of 4 children in each home. So that way, the treatment parents have a maximum of 4 kids that they can work with every day on, you know, learning how to be respectful, learning boundaries, learning to cooperate, learning not to have to control everything that everybody says and does, that they get the attention that they need in a healthy way instead of demanding attention in an unhealthy way. So it's a smaller milieu for the child to be able to learn those skills and frankly to replicate what they need to go home to. It's always nice when we can say your child's going to be a different child when they come home, and to be able to tell the child you're going to have different parents too.
Yes, yes, yes.
They look the same.
Yes.
But they're
everybody
different.
looks the same. Everybody looks the same.
Yeah.
Yeah. But the program changes. Yeah.
Right. Yeah.
Yeah. So yes. So we're the beginning of that. There's quite a few differences, I think. So, you know, the goal is to help the kids attach and bond and deal with their trauma and feel safe with their parents and be able to learn to trust them. And if they can only do that a little at a time, fine. That's typically it's incremental anyway.
Yeah. So let me talk a little bit about neurofeedback. We've mentioned it a couple of times as we've been talking, and not everybody knows what neurofeedback is, and some people do. When I'm talking to parents when they're inquiring about our program, some have actually used it in the past. So basically, it is a mapping of the brain that is done, and that is done initially. And what it shows is the areas of the brain that are underactive, overactive, where the trauma kind of sits. I mean, it sits in different places for different people. That depends on age, development, you know, just a lot of things. And so once that mapping is done, then though these sessions, and everybody says, oh, do you put electrodes on my head? No, they're just sensors. You don't feel anything. And they just kind of glue them on with a little gel on your head. And they
not permanent glue.
No, it's just kind of icky in your hair. So what they do is, from that initial mapping of the brain that they do, then they know where to put the sensors, because it'll be different for every person. Mm-hmm. So they do that, and they go through several sessions, like 16 sessions, and then they do that mapping again and see how things have changed. We often know that changes have happened because we see behavior change, anxiety has gone down, kids are easier to manage. And so they do, in our program, they go through 2 long sessions of, I think it's 16 sessions, and then they do the cue again, and then they do another 16 sessions. Sometimes we do a third. We often do just 2, but sometimes a third. Depends on what's there. It's been very beneficial. For a long time, people thought it was voodoo and that it wasn't anything, that it was just kind of some hokey pokey thing that somebody came up with electronics. But we do have a lot of research behind it that it is very helpful. And I can tell you that I have been using it because I'm a terrible sleeper, and I've been using it now, and I am sleeping better than I've slept in my life without medication.
Yay.
So yeah, I say yay too. I'm not as tired anymore. So you can use it for a lot of things. Many times people will use neurofeedback out in the community for ADD, ADHD, and typically where they target is the prefrontal lobe for that. But we go much further, much further. All of our protocols are very scientifically based in how to treat certain things and where the trauma is, and all of those kinds of things. So if you're interested in the neurofeedback, you might want to look up some articles about it. The people that we use here is the Mind Gym, and I know that they have some videos and they have some resources on their website. So you might want to go there. There's other places. I'm not just plugging Mind Gym, but those are the people that we use. So it's pretty interesting stuff, and it has really been helpful for our kids for sure.
Yeah, and you can look at EEG neurofeedback as well as neurofeedback. It's the same, but EEG is sometimes in front of the word neurofeedback.
Yeah. So I think that we have come to the end of our questions.
I think so.
For this fireside chat.
Yes, I'm looking forward to the next set of questions. I hope everybody will keep sending in their questions and tuning in and listening. And we sure appreciate everybody that joins our chats. So keep sending in your questions. Again, I will go ahead and put the number out there for the Institute for Attachment and Child Development. It's 303-674-1910. So Institute for Attachment and Child Development, 303-674-1910. If you want to reach me, it's Beverly at instituteforattachment.org. And Roxanne is Roxanne at instituteforattachment.org, or just give a call.
Yeah.
Thanks, everybody.
Thank you.
Bye, Roxanne.
Bye, Bev.